This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name unless referring to a medicine listed on the PBS, in which case we'll use the commercial name. Please note that availability can vary between Australia and Aotearoa, New Zealand.
Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest guidelines and research in obstetrics and gynecology through the conversations with leading experts. Postpartum hemorrhage, PPH, is one of the most prevalent complications of childbirth and accounts for nearly 1/5 of maternal deaths. In 2025, the World Health Organization, the International Federation of Gynecology and Obstetrics, FIGO, and the International Confederation of Midwives, ICM, released consolidated guidelines for the prevention, diagnosis, and treatment of postpartum hemorrhage. Today, we'll be discussing these guidelines, some of their key recommendations, and how they can be applied in local Australian and Aotearoa New Zealand contexts. I'm your host, Dr Nisha Khot. I'm an obstetrician and gynecologist based in Melbourne, and I'm the president of RANZCOG. Joining me today are Associate Professor Stefan Kane and Professor Joshua Vogel. Stefan and Josh, could you please tell us a little bit more about yourselves and your experiences with today's topic?
Thank you, Nisha. It's a privilege to be here. Thank you for the opportunity. As you said, my name's Stefan Kane. I'm a maternal fetal medicine subspecialist obstetrician based at the Royal Women's in Melbourne, where I have the privilege of serving as the Director of Maternity Services and the Acting Director of MFM. And I also have a small private practice as well. So in both of these roles, both clinically and from a governance perspective, I perhaps unfortunately have extensive experience in PPH, trying to work out the best ways of preventing it and then managing it when it does happen, and looking at the structures we put in place to support women and families who sustain this.
Thanks, Stefan. Josh?
Thanks, Nisha. Also great to be here. So I'm Co-Program Director for Women's, Children's and Adolescent Health at the Burnett Institute here in Melbourne. So my background is I'm a medical doctor and a perinatal epidemiologist. I worked at the World Health Organization in Geneva for several years, but the last several years here in Melbourne developing and running a research team, the Global Women's and Newborns Health team. So we have projects in 20 countries around the world working on major issues in maternal and perinatal health, including postpartum hemorrhage, but we're really focused on limited resource settings. So we have a number of activities in the Asia Pacific, South Asia and Sub-Saharan Africa as well.
Lovely to have both of you here. Before we begin, I'd like to invite you to declare any relevant conflicts of interest. Stefan?
I do have some. I have received remuneration for providing advice to a manufacturer of a PPH device and also providing advice as part of an editorial or an advisory board for an intravenous iron manufacturer as well.
Thank you. And Josh?
My position's funded by public money, by NHMRC in a research role, and also we receive competitive grants and philanthropic grants. In this case, I've actually worked on WHO's postpartum hemorrhage guidelines several times, and we receive funding from WHO for that work.
Thanks very much. Josh, let's start with you. Tell us why we needed an international guideline like this one.
Sure. Look, it's been a big couple of years in this space. WHO's convened a group to produce a roadmap on how to combat postpartum hemorrhage, as we know, is the leading cause of maternal death worldwide. Tragically still a major problem despite everything we know about it for so long. Historically, I think recommendations have come somewhat in dribs and drabs. One focused on treatment or prevention. What this does is it brings everything into one place, a sort of a one-stop shop for everything related to prevention, detection and management of PPH. The other thing that's actually really impressive about this piece of work is getting that shared voice between WHO, the midwifery and the obstetric community with ICM and FIGO. So this is the first ever guideline that's been completely co-owned by those three organisations, all taking this evidence-based approach to best practice.
That's really great. Anything we do together as a multidisciplinary team is more likely to be beneficial in the long run. So that is fabulous to hear. Stefan, what does it look like in our context?
Yeah, thanks, Nisha. PPH is still obviously clearly clinically very, very important. We're in the fortunate position in a high-income setting where most women birthing in Australia have access to very high-quality care, where death is rare, but we still have 8.2 deaths per 100,000 women giving birth in Australia in 2023, and 4 of those deaths, according to the AIHW, were related to obstetric hemorrhage. So it's still really important, but I guess the mortality statistics only give a small part of the picture. It's the morbidity, the huge impact on women and their families who sustain PPH that we notice and that is such a focus of our care. And the rates haven't really budged a huge deal despite extensive efforts made to reduce them. And there's a number of reasons for that. One of them might be, ironically, that we're better at identifying them. Now we're measuring blood loss more than, and we'll come to this later, but measuring it rather than just estimating it. There's a lot of attention paid to it. So we're picking up on rates of PPH. And also I think the birthing population has probably changed a bit as well. We now have women who are have greater BMIs, who are older and have comorbidities that will increase their chance of having a PPH primarily, or increase the chance of having or requiring forms of obstetric assistance that themselves will perhaps increase the chance of PPH as well. So it's still very much something for us to focus on, I think, in the local context, both in terms of prevention, but also really good acute treatment when it happens.
And that is so true. I mean, all of us who work in obstetrics, we see PPH on a regular daily basis. And so we really do need guidelines to make sure that we're providing the appropriate care. Josh, there's been a change in the threshold for diagnosing PPH. What is this change and why?
It's the case that this consolidated guideline, a lot of the recommendations will be familiar to people, but there are some changes. It's probably the most interesting one, in my opinion. So historically, we've considered PPH to be 500 mils or more of blood loss, regardless of mode of birth. But if you scrutinise the historical evidence, not really clear that that was based on evidence. It has a charming simplicity and practicality, but really you couldn't point to a study and say, this is definitely the best definition in terms of getting the best outcomes. I think we'll talk a little today about first response treatment, but certainly research in that space has signalled how important it is to have a good objective measurement, know exactly how much blood loss is there, because that's when you trigger those effective treatments that can save lives. What's happened here is that WHO and colleagues have put out a global call for data. They've pooled all that data into a meta-analysis, an individual participant meta-analysis published in Lancet last year. They've actually asked the question, is this the best definition that we should be using, or is there a better one? And that was what was so striking about this new definition. It's shown that using a 300 mil cutoff plus clinical signs is actually more effective than using the historical 500 mil cutoff. That's not to say that 500 mil isn't useful or important, but it seems that treating a little bit earlier is actually more helpful and more effective. So we can make that claim in the guideline in an evidence-based fashion, but obviously this does have some implications about how we approach care. But I think the message is also there. We can't neglect the clinical signs and symptoms of the patient, not simply just making a blood loss estimation.
That's really key to it, isn't it? Using a number doesn't really make sense if we're not actually focusing on the person in front of us who's actually showing us those signs and symptoms. Stefan, what is different about detection of PPH? What are some of the recommended approaches?
Well, I guess coming back to Josh's point there, I think this is really helpful to focus on some, using hemodynamic instability, I guess, as a marker, rather than just waiting for an arbitrary threshold and then saying, right, we've got a PPH now, let's get in and treat it. Instead, thinking, and there will be, I guess, part of this is that, as you say, using a set number for all of our birthing women is not helpful. Some will be able to sustain losses of 500 mils or more and be fine. Others, by virtue of their size or pre-existing or pre-labour hemoglobin or whatever, will have less reserve. And so acting earlier for those women with less reserve is really important. So I think that's really helpful. And it will be interesting to see once this does, as it hopefully will, get rolled out into practice in Australia, what impact that will have on our rates. But certainly also on that proactive early treatment. The other key component here, I think, is that visual estimation is really not great. We know this well, and yet we still sort of fall back on it because many of us, it's how we were trained, and you think, oh, well, it's not too bad, and their obs are fine, it's going to be okay, when in fact they've lost close to a litre, and many will be fine. That's the thing. We are generally providing care for healthy younger women who are fine and can sustain a degree of blood loss. So that's where this strict approach to measurement is helpful. And this is both true at both vaginal births and at caesareans with volumetric drapes, so drapes that have measures built into them so you can see how much has been lost, an estimation of blood loss at caesarean prior to incising the uterus so you have an idea before you mix it with Lycor, things like that can really help objectify the measurement. And so it's not just that random guess that goes on, which we would naturally err on the side of underestimating how much blood loss there has been. And I guess the other really important component here is not letting our desire to identify PPHs early and prevent them ideally, making sure that these measures are done in a culturally safe and appropriate way, and that women's preferences regarding birthing position and the room environment and things can be accommodated to the greatest extent possible. And I think it is possible to achieve that, especially with good antenatal education around the importance of preventing PPH as well.
Josh, the guideline also talks about things we can do for prevention of PPH. What are some of those interventions?
One interesting change in this guideline is taking perhaps that much broader approach and thinking critically about the fact that prevention starts antenatally, to Stefan's point. That ensuring women are as optimally healthy going into birth as possible is a big part of that. And certainly guidelines like these, which are aimed at a global context, we're thinking a lot about anemia and how we can recognise it early, test for it accurately, and try and prevent and treat it antenatally or postnatally if need be. One recommendation that may interest the audience is the changes around IV iron, which in a global sense is a relatively new player in terms of interventions, but offers that opportunity to really improve the treatment of anemia as well. I think postpartum, there's been a well-established body of evidence about the importance of early uterotonic use, 1 to 3 minutes after birth ideally, and historically that's been oxytocin. There's been an update to the Cochrane Review Network meta-analysis, not just adding all the new trials of uterotonics for prevention, but also I think a bit of a re-examination of the evidence and make sure that we're not being misled by trials that may have had problems or brought some biases into that body of evidence. So there's a very clear message there about oxytocin as a first line, misoprostol and carbetocin as well as alternatives, and a number of other uterotonics that are not seeming to be effective for prevention.
AFOG is headed down under. The 2026 Asia Oceanic Congress will be hosted by RANZCOG from the 12th to 15th October on Gadigal Country, Sydney, focusing on the theme Equivolution, Equity and Sustainability in Women's Health. The programme will cover topics such as environmental sustainability, equity in education and leadership, as well as equitable healthcare for women of all backgrounds. This is your opportunity to be a part of our region's largest O&G event. Connect with international experts in the field and learn about innovative research from across Asia and Oceania. And don't forget to soak up Sydney's stunning nature, food and culture. Early bird registration is now open until June 2026. Book your spot today to get the best prices. Visit aofog2026.com to learn more.
Stefan, what about retained placenta? We've spoken about uterotonics after baby's born and after placenta is born or around that third stage, but what if there's a retained placenta?
Yeah, so I guess retained, you can have the whole placenta retained, of course, or part of it retained. And for the latter, I think a very low threshold for going to theatre and performing a proper examination to ensure the uterus is empty is really important. And I think we still see women who sustain primary or secondary PPHs in the context of an incompletely evacuated uterus where there was a suspicion of an incomplete placenta. With a fully retained placenta, again, I prompt identification and going through the usual steps of achieving the third stage, achieving birth of the placenta, but then using uterotonics during that time if there is ongoing bleeding is something that certainly at the Royal Women's we've introduced a little while ago in our guideline on the basis of the fact that prior to that people were concerned about the uterus clamping down on the placenta, making it more difficult to get out, and so not giving uterotonics, but then you'd have this combination of atony and tissue, I guess, of the 4 Ts, the tone and the tissue causing the bleeding, whereas giving the uterotonics can help at least address the tone, a bit of the tone part, acknowledging that the uterus won't fully retract or contract until you've removed the placenta, but it can help stem some of the bleeding en route to theatre, where that's often where you need to be to remove it.
That's really important, because I have also heard repeatedly this kind of controversy around, should we give uterotonics? Will the uterus clamp down and then it'll be more difficult to remove the placenta? And so it's really good to hear that there are these clear guidelines that you just give the uterotonics.
Yeah.
Irrespective of when you're going to get that placenta out, because you might be delayed getting to theatre.
Indeed. And the uterotonics themselves might help the placenta separate and come out as well.
Absolutely.
So there's that bonus. And the challenge of a really sort of contracted, or I guess reformed cervix, is in practice not something I'm overly concerned about, I guess.
Josh, we've spoken about prevention, so let's move on to first response treatment. The guideline encourages rapid initiation of first response treatment. What does that look like? What is this treatment bundle that the guideline is talking about?
For a researcher, it's just been actually a really exciting last few years in the PPH space. I think people are aware of the Woman trial showing the importance of adding tranexamic acid into the treatment cascade, and more recently the large cluster randomized emotive trial. So that's shown that this package, this bundle of first response interventions is really influential. I think key innovation around the emotive trial is linking that objective routine measurement of blood loss, the early recognition of the postpartum hemorrhage, and triggering those interventions quickly and concurrently. I think what the data has shown, and this may or may not be true of Australia and New Zealand, but certainly true of many countries in the world, is that even when the interventions were being used, they were being used maybe sequentially or in a delayed fashion. You take tranexamic acid as an example, it's very sensitive to timing in terms of its beneficial effects, and we don't see the effect 3 hours after the diagnosis, 3 or more hours after the diagnosis of PPH. So really packaging that together to allow people to trigger those interventions quickly. And, I think the final thing is emotive. It's a very clever acronym, easy to remember. So early detection, M, massage, uterine massage, O for oxytocic, T for the tranexamic acid, IV fluids, and then E for examination and for escalation of care where required. So that's proven to be wildly successful in terms of improving outcomes, and it's now a global standard of care around the world.
Excellent. We all love a good mnemonic, don't we? Stefan, let's focus on refractory PPH. What does the guideline recommend in the instance that a patient is not responding to all of the first response treatments?
Yes, well, fortunately, most of our patients do, which is good, but 10 to 20% are to some degree unresponsive. And it's really important that we have a consistent approach as teams on the ground to managing this. The first step, of course, is recognizing it and not getting stuck in that confirmation bias, it's settling down, it's getting better, but actually being very strict. And again, this is where volumetric measurement can be very helpful, because objectively we can say, actually, no, there is still ongoing bleeding. It's not just a trickle, which is, I think, one of the most dangerous words you can use in obstetrics, it's actually there is active bleeding. We haven't got it under control. What else do we need to do to help address that? And the doing and what we do in what order or concurrently is as important as the team-based approach to making that happen. And I think that's where, having a culture of psychological safety where people can speak up and say, actually, I'm concerned, there is still ongoing bleeding. What are we as a team going to do about that, no matter what role they have, is a critical component too. I guess the key steps would depend to some extent on one's context, where one is, and the things that one has access to. But the ongoing manual measures like manual compression is very effective. It's not easy to do. You have to use a lot of effort, and particularly in people who are larger, it can be very difficult. But that physical pressure on the uterus can make a huge difference in terms of ongoing bleeding from atony specifically. And then I think a lower threshold for going to theatre, as I mentioned before, that's really important, because that's where you have the assistance, the anaesthetic support, the lighting, the environment where it is easier to implement these interventions, and you are less likely, I think, to be given to that confirmation bias of thinking, it's okay. Whereas there you don't have those perhaps psychological barriers. You're in the place where you can do whatever perhaps needs to be done. And I guess the extreme end would be things like a laparotomy for uterine artery ligation or B-linked suture. Certainly B-linked suture has, I think, reasonably good evidence to show that it's helpful. And in our clinical experience, it certainly has been a very good way of stemming bleeding and averting hysterectomy. But of course, hysterectomy remains the gold standard, and there are lots of reports from investigations into maternal deaths about delays in wanting to do a hysterectomy or feeling like you should do a hysterectomy, leading to poor outcomes. And despite our access to all these other treatments, it is still the thing that is going to save lives, and we should not hesitate to do it where it's required. Other things like cell salvage and so forth, I think, again, it depends very much on the context. Where we anticipate there is going to be a PPH, for example, placenta accreta spectrum, then it's a bit easier to set up in advance. I think in the acute context, with an unanticipated PPH, it would very much depend on the local environment and the resources and facilities that are available. Again, it's a type of thing, a bit like interventional radiology, that you wouldn't want to delay providing treatment waiting for that type of thing. And again, there's that risk of avoiding going down the definitive pathway, waiting for these other modalities that necessarily will take more time. So thinking about, well, what do we need to do now that's going to save a life, basically.
Having a PPH sounds like a really traumatic event. How do we ensure that we are providing that emotional and psychological support for women who are recovering from PPH, in addition to all the physical supports that obviously we will provide for recovery?
This is such an important area, and there are so many aspects to it. Obviously, birth trauma is very appropriately and understandably in the media, in our day-to-day conversations a lot. And one of the contributors to that has historically and continues to be PPH. Part of it, I think, is antenatal education around the possibility of this happening, and if it does happen, what is going to happen, what care are we going to provide to minimise it from happening, to minimise the impacts of it if it does happen. I think that's something that we perhaps don't do as well as we could or need to. There's a natural desire maybe not to go through all the things that might go wrong when you're talking antenatally, and we sometimes get accused of being too negative and talking up these things that are rare. But the issue here is that this isn't rare. A significant proportion of our women will experience a PPH. So some antenatal preparation for the possibility, and why we recommend active management of the third stage with a uterotonic, why we will be monitoring very carefully for blood loss after birth is very important, I think. When it is happening, the clarity of the communication, the effectiveness of the teamwork really makes, I think, in my experience in conversations with women who've sustained a PPH, makes a big difference to their impressions of care and how safe and secure they feel. So we clinically have had women who've had very, very large PPHs who have needed to go to theatre to have extensive support, extensive interventions, who afterwards have not sustained trauma, who have felt very well cared for and have felt safe and secure because they were aware of it as a possibility. They had good communication as it was happening. They knew what was going on and why. And afterwards, they were debriefed really effectively. So I think those things, obviously it will be different for different women in different contexts. And for some people, there will always be potentially a degree of trauma that we'll need to provide support for and manage. But I think good communication at the time, and not just communication with the patient, but some of the feedback we've received over recent years has been the impact of the way in which we communicate with each other as the treating team and how that is perceived by the patient. So patients who see us communicating effectively, respectfully, clearly, and with I guess, a clear purpose, that gets interpreted very favourably and positively by patients. Whereas we can be as nice as we want to the patient, but if they pick up that we are interacting in an unprofessional or panicked way, then that doesn't instill confidence. And I think that's an important component. The other really important component is the partner and the family. And they often get a bit forgotten. I think we're better at this now. I think we're better at communicating with them, but particularly if the woman has had to go to theatre and the poor partner's left in the birthing room with the baby, literally left holding the baby, it can be a terrifying time. And so having the presence of mind to go and speak to them, update them, let them know what's happening is really important as well. Because again, we've seen some instances recently where the mother hasn't reported any trauma, but the partner has been traumatized by this experience and feeling that sense of hopelessness and helplessness and not knowing what was happening. So I think that's an important part of the healing as well.
I would agree with that wholeheartedly, because that is what I also hear from women who feel really well supported and well cared for, and similarly from partners as well, when the team communicates well amongst themselves and with the woman as well as her family. So thanks for highlighting that, Stefan. That is something that everybody should really keep an eye out for. The guideline emphasizes that we should adapt locally, whatever it is that the guideline says. Drawing on your experience, what health system level interventions do you think are most important for supporting effective implementation in our part of the world?
So it'll be interesting to see, I guess, over time, which elements of this and how they're applied. I think the new definition would be a really important one to try to bring in. And then other elements, many of them are already there. We were discussing before about the iron question, which is, I think the treatment of iron deficiency anemia is not in question at all, but the extent to which we treat iron deficiency alone, particularly very mild levels with a normal hemoglobin, I guess there's some more work and debate to be had there. I think the other key things ideally would be consistency across, obviously within an institution, but then across health services as well. And in the Australian context, that's probably achieved more easily in some jurisdictions than others. Some have very well-established central guideline writing and quality improvement agencies that have very good outreach into all maternity services. Other jurisdictions are more devolved and leave things more to the local level. Either way, there really does need to be sort of clear, consistent guidance at whatever level it is achieved. And then looking at ways of implementation, I think, again, that's something we haven't necessarily, not just in maternity care, but in medicine more broadly, that implementation piece of research of guidelines is something where we often fall down. And how we look at getting guidelines into practice and ensuring that work as imagined, work as done, and work as prescribed are all the same, that the Venn diagram is maximally overlapping. Is a challenge, I think, and that's where simulation and team-based training and making sure that flowcharts are tested and trialed by people with human factors experience can make sure that we don't just say this is what you should do, but then go on doing something different. That we actually practice what our guidelines preach. That's really important, I think.
Josh, the guideline identifies a whole host of research gaps. What sort of research gaps are there?
Well, if you're short of ideas for a PhD for yourself, just turn to the back and there's enough work there for the rest of your lifetime. I will say, WHO can only go where the evidence leads them. And so I think in some ways the research gaps and what needs to happen next is as important as the recommendations and practice changes we've been discussing. Just to pick up on a couple, I think, that we've touched on today. One is that while this revised therapeutic definition applies to all modes of birth, we do have relatively less evidence for caesarean section. We know what's going on with escalating rates. In our part of the world, I think we're going to go through 35-40% of rates in the Asia Pacific and Oceania in the near future. So it's becoming increasingly a larger mediator of PPH-related outcomes overall. So to what degree these definitions and objective measurement approaches work as well as possible in caesarean sections, a big area where we need more work. We touched on earlier on refractory PPH management and devices. This is a tricky space because they're difficult trials to do and they cannot be done without international collaborations. Typically, tertiary centres with large numbers of women giving birth and appreciating the complexities of how this is done. The truth is we do need those randomised comparisons if we have any hope of knowing how to improve refractory PPH management. The final, I will say, is this point Stefan was speaking to about how do we optimise women's experience and the antenatal education elements. So that's an area where there's just so much work to be done. Everything Stefan has said for postpartum hemorrhage, I think, could have been said about preeclampsia or about infection or any number of morbidities. But I think in the case of PPH, acknowledging that most women who have one are low risk for PPH antenatally, and we really do need to take that more universal education approach. And that's where there's just a very too limited evidence base in terms of what providers and health systems can offer.
Stefan, Joshua, thank you so much for sharing your insights with us today. You can read the full consolidated guidelines for the prevention, diagnosis, and treatment of postpartum hemorrhage via the link in the show notes. If you enjoyed this episode, please rate, review, subscribe, and share. And don't forget, RANZCOG members can log CPD hours using the form attached in today's show notes. We'll be back soon with more conversations on Talking O&G.